طيب بسم الله الرحمن الرحيم. السلام عليكم. I'm Dr. Taysir Al-Taib. So happy to be with you this night and more happy to get you at Altababa hospitality. I do believe that you have to get benefit from the others' experiences as you may not have the time to pass through them all. I promised you before that this session will be unique as is the last one for this year. We at Altababa Advanced Training Center, ATC, have a project called Expatriates Online Sessions. These sessions usually presented online from the finest scientists from outside Sudan to benefit from their experiences. The great project aims to spread knowledge and the latest scientific development and personal experiences of the Sudanese scientists who are outside the borders of the homeland, but whose roots are buried deep in the fertile land of its Nile. This project started as a giant, but its success did not come easy. The hardest thing was to continue and benefit from the experiences to improve performance so that it reaches you in such a great way. Quality improvement is what we strive to maintain, not just to sing in the successes of the past. Our ethos is to continue challenging ourselves, and that's what distinguishes us in Altababa. We have been living this project in its bright form since the 1st of May this year, and the first session was what we didn't know about COVID-19 presented by فضيلة أستاذنا Professor Muhammad Al-Mu'tasim Abdelbagi, and it was online Skype session that time. The achievements have been made to reach 20 lectures so far. The total number of attendees and participants as well as followers on social media reached 9,185 from inside and outside Sudan. Yes, that's right, 9,185. We started with simple possibilities and we tried every platform that could come to your mind. Listen to every critical and opinion and every advice. We have had difficulties in selecting the topics to suit local needs and keep pace with global developments. We have difficulties with the power supply and the stability of the internet flow. How difficult our honorable scientists have been because of their time constraints and because of the time difference between them and our local timing. The bright side is what is presented to you, but behind it was extensive logistics preparation, sessions of brainstorm, horrible documentation, and complex network of communication and organization. I would like to thank from the bottom of my heart all those who stood behind this wonderful achievement and did not spare their time, advice, or knowledge to give it free to doctors of my beloved country. I thank you very much. And I repeat very strongly, Engineer Rayyan, Engineer of Information Technology, and Mr. Salah Ad-Din Al-Zubair for their extraordinary efforts and patience. There are people who the said words of thanks are not fair for them, and we have left the reward to Allah, who is only able to bless them. Professor Muhammad Al-Mu'tasim Abdelbagi, Professor Salah Maghribi, Dr. Mustafa Hashim, Dr. Fathi Noor Al-Zain, Dr. Qasm Al-Sid Yusuf, دكتور غادة عثمان، بروفيسور لي وليس، دكتور أمين التجاني، دكتور خديجة أبو القاسم، دكتور عبد الله الغامدي، دكتور عبد الماجد أحمد، ودكتور خالد غالب. And I thank all those who have reached out to, but their commitments had not helped them to be with us. شكر خاص جدا وكل التقدير والعرفان أستاذنا الجليل دكتور طارق عوض الذي لم يبخل بكل وقته وعلاقاته الممتدة. كنا أحيانا لوقت متأخر ننسق لمحاضرة أو نتواصل مع أحد علمائنا الأجلاء. I cannot fail to thank all the wonderful team, transformation leaders team that worked hard for the success of this pioneering project with all sincerity and loyalty to the great Altababa. دكتور حافظ، دكتور البدري، دكتور عبد الماجد، دكتور عبد المنعم، بروف مبارك، دكتور عوض، وكل السادة أعضاء البورد الموقرين، كل الشكر والتقدير لدعمكم المتواصل وثقتكم المقدرة. بروف عماد صلاح، لم أجد ما يقال ولكن وجدت أن أقدم لكم the success of this project Expatriates Online Sessions from Altababa Advanced Training Center. فهو منكم وإليكم ودعواتنا جميعا لكم. أسأل الله أن تكون في نصيبكم. I am and many of my colleagues are proud that we're being taught and trained by Dr. Hala Abuzeid, and we are still learning the meanings of impartiality, humility, and giving, and so much. Dr. Hala Abuzeid, we are really honored to be with you tonight, the beast in critical care, the ins and outs. Generous audience, we made the microphones muted. Pardon. If you have any comments or questions, you may feel free to raise your hands or write it in the chat. دكتورة هالة أبو زيد، your ground، تفضل مشكورة.
Right. Is the sound okay so far?
Yes, okay, Dr. Hala. Let me
Very good.
get out of the sharing. Just a minute.
That's great. Thank you very much indeed. And can you see this slide?
Not yet, Dr. Hala.
Okay.
After a while, maybe. Yes.
Did it get to you?
Yes, positive.
So, all right, that's fine. Great. طيب بسم الله الرحمن الرحيم. شكرا جزيلا على الاستضافة، وحقيقة very privileged يعني listening to what Altababa has done so far over the last year, and I feel very small being part of this huge team, the best team that you just mentioned right now. A lot of professors and a lot of teachers and a lot of very senior colleagues, and I'm very privileged. وأتمنى إنه أكون يعني the last session of the year to be one of those good sessions that will help our junior doctors and hopefully our Sudanese patients as well. And معنا في الحضور بروفيسور صلاح مغربي، دكتور عماد، يعني لكم مني كل التقدير والاحترام على ما بتبذلوه يعني من على البعد، ونتمنى إنه نكون يعني نكون زيكم كده بسيط، يعني نقدر نقدم الحاجات اللي قدمتوها وما وقفتكم لا كهرباء ولا نور ولا بعد مسافي، ونتعلم منكم دائما. شكرا تيسير، شكر جزيل جدا على الاستضافة. و today I will talk about the beast in ICU, and obviously the beast is what I'm referring to, and we all talk about COVID-19 for the last year. Now, I'm not sure whether there will be COVID-20 or not. I think there will, with the new mutations coming out, but definitely all our lives have changed dramatically in the year 2020, and we can't just wait for 2020 just to move on and to finish, to see another year that is at least COVID-19 clear. And I will look into the beast from all points of view, but I will concentrate in intensive care, acknowledging the fact that when I address doctors coming from Sudan or working in Sudan, they will have a lot of challenges. By all means, this is an educational session, but at the same time, it might just throw at our junior doctors some tips to try and help our patients with. No matter what we seem to know about COVID-19, but at the end of the day, it's a novel disease. And at the end of the day, every day we learn something about COVID-19, be it at home at the beginning of the illness or later on when the illness progresses to even hospital admission or critical care admission. So I don't have any disclosures to share with you. Let's dive into the talk that hopefully by the end of this talk, we will just have an idea about where we are globally and how the burden has affected not only one country or another, but mostly all continents. And it just in our minds, it's probably mimicking the Spanish flu that we witnessed in the 1920s. The ICU stay and what happens during ICU. A little bit to say about vaccination and all the murmuring we talk about regarding vaccination these days, and the new strain, and a few words about long COVID and the future. Now, globally, this is just a last census. A lot of people died, as simple as that, but a lot of people are affected. I think now the United States are amongst the highest countries affected, and we all know that. We know that it's a fact that the first hit we had was around the March timing, and now we're having the second wave starting, and maybe a third wave, who knows. but it definitely killed about almost 1,700,000 people. Yeah, a lot of people have recovered, but we're still not out of the woods yet. And the disease, by the looks of it, keeps waxing and waning. Now, a lot of things is not known yet about Africa. And I think that we cannot bury ourselves into the sand by saying Africa doesn't have the disease or is going to be resistant to the disease. I think Africa will be like other countries, exposed to the disease with the globalization, with the traffic, with the airplanes, with the flights, and absolutely with the lack of testing or the difficulty in testing. So I will take anybody who tells me that Africa doesn't have the disease or Africans are going to be immune to the disease, I'll take that with a pinch of salt before I believe it. Now, obviously, the disease has got a lot of burdens when it comes to economy, when it comes to human lives, and when it comes to productive lives that it kills. It does not differentiate between a man or a woman. It does not differentiate between a black or a white. It does not differentiate between a young and an old. We've seen COVID affecting very young babies, and we've seen COVID affecting the younger population. It doesn't have to be in the severe form, but we've seen it affecting the elder age group from all nationalities. And then when it comes to money and how it affects the economy worldwide very negatively, then it is definitely not a secret to understand that it scooped all the energy and all the financial support in all the countries and all the continents. And the amount of money spent around COVID testing and COVID protection and COVID diagnosis and treatment and critical care and so forth is huge. But I think the amount of money that will be kind of a loss or lost will happen to be seen after the COVID era, because we will find economists kind of flattening down and even becoming sicker themselves. Now, let's talk about facts. And the facts that we know about the disease are quite minimal because it's a novel disease. It was a new virus. We have part of this group of viruses, what we call the coronaviruses. Some of them we dealt with in 2011 and 2015, the SARS and the MERS, but the COVID-19 is not SARS and it's not MERS. It did not, or it is not behaving like the above mentioned two. And most of us dealt with COVID-19, we probably have dealt with SARS and MERS, and the clinical picture is completely different. Now, the behavior keeps changing, but we will discuss in a minute the major issues that are seen amidst the COVID-19 infection. But usually when it comes to the new mutations, I don't know what we are expecting to see, but very likely that we're expecting high transmission and but not virulence. And definitely what we saw of COVID-19, there is nothing to be seen other than it's an aggressive disease, especially in the severe forms. Now, when we look at the beast itself, everybody knows how it looks like. It got its name COVID or Corona because of its crown-shaped kind of phenotype with the spikes, the proteins that are showing themselves outside in the outer layer, and that are really where the issues around vaccination and issues around entry of virus into the cell takes place. And a lot of talking has been directed towards these spikes, and obviously the inner layer being the normal inner layer of any coronavirus, consistent of a genome and a nucleosides, and obviously a membrane that is very stubborn and very thick with phospholipids and so forth. The cartoon above there will show you how this particle is compared to other particles, including bacillus or red blood cells. It's very minute, and I made it deliberately appear that the particles are small, but are bigger than the filters that we have in all the masks, and hence why masks are very important, because they can just filter the coronavirus, and it could be one of the very important preventative measures that can help dampen the disease down. So where it hits hard the lungs, but definitely there is no other organ in the body that COVID-19 didn't touch. It touched the brain and presents in very bizarre forms of diseases, mainly venous accidents, and obviously mainly arterial accidents, but we've been seeing a lot of venous accidents compared to arterial incidents. It can obviously present in the initial stage during the virulent incubation period with the headache, the malaise, and obviously the general meningism features that anybody who had a viral illness probably exhibited. When it affected the renal system, it can come in many forms, but when we see people in critical care, they usually come with acute kidney injury in about 20 to 30% of the population. And it even affected the liver, leading to transient transaminases elevation and a status of hepatitis, a viral hepatitis, that hopefully with the eradication of the disease, things get back to normal. 20% of patients present with things like diarrhea at the beginning of the illness, and if obviously the nauseas and the malaise can be part of the initial presentation as well. Interestingly, thromboembolism has been talked about very much within the COVID-19 issue, and there are a lot of talks around how to deal with them and how to diagnose them. And in fact, it's been thought that the major problem in the lung is to do with shunting and ventilation perfusion mismatches, and hence small microemboli. And deep vein thrombosis, obviously secondary to the dehydration and secondary to the thrombotic phenomena that happens in the vascular system, is one of the other presentations. When it comes to the heart is very sensitive, and as part of any viral illness, myocarditis is one of the manifestations, but with COVID-19, it tended to be seen quite often. And obviously, with the initial medications that we've been practicing giving patients with COVID-19, due to the limited studies that we had initially from the Chinese data in the early January, February, March timing, we had additional pharmaceutical agents, including the azithromycins and the hydroxychloroquines, added to the cardiac manifestations, including QT intervals and obviously the myocarditis. Dermatological manifestations tends to be in anything from urticarial rashes to things like livedo reticularis or even vesicles. Now, the golden treatment for COVID-19 is obviously to prevent it to start with. But obviously, once you have it in your system, you have to deal with it one way or another. So the initial preventative measures and recognizing that it's important to keep the hand hygiene, to keep the mask on the face, and to keep the space around social distancing, and recently they're replaced, keep the aeration and the ventilation appropriate. And quite a lot of people were mentioning that COVID-19 wouldn't perhaps affect people during summer period, but it tends to increase during winter period. And I think there are a lot of clues to why this could be happening, but there are no clear evidence. But you might think that maybe when people are within the winter timing, studied in certain areas together, maybe this will lead to more and more of the circulation of the virus, and hence the replace of the air is one of the important measures in prevention. Now, this is just a cartoon to show you that the N95 mask and others are important, not because they are fancy or they make you breathe in and out your CO2 and get headaches or have a good seal, but no, it's because of the fiber and because of the fact that it is by and large the best mask that will stop all viruses and even bacteria from traversing, and even the coronavirus, measuring the measurement we have seen in the previous cartoon of up to about 0.1 microgram. Now, practically speaking, people who get the touch of the flu, who are at home, who are doing very well, they might not need to be having nothing other than being documented to having COVID-19 or not, so as to stop them from propagating the infection to their household. And one of the most important things is we never could identify how much is the community transmission amongst people within countries. That's why we were very blinded by the infection rates in certain places versus the other. But if the patient ended up needing a degree of oxygen therapy, you know, simple things that might not be known to our junior doctors or even to us within our hospital household might affect our choices. So when we come to oxygen delivery, and I understand these days, even in Sudan, when people are sick and the hospitals are studded with a lot of patients that are in spaces, people now are having the habit of getting their loved ones oxygen cylinders to give them oxygen at home. Well, as much as this is a risky maneuver, but if it is a must, then we have to have an idea about how to deliver that. But obviously take all the precautions necessary when we are doing that, because an oxygen cylinder in a Sudanese household is a bombshell. You know, people cook, people smoke. You know, it's very, very dangerous. So you have to be very cautious. Rather than treating someone with their oxygen cylinder and trying to give them the breath of life, you end up causing a problem to you and to the community surrounding you. But if it's a must and it has to happen, then you have to apply all the precautions, but you have to know what you need to deal with. So the delivery systems are anything going from the basic nasal cannula, as far as the simple mask and non-rebreather mask, up to obviously maneuvers of non-invasive ventilation and later on the TPs. But each and every one of those will deliver oxygen in a certain percentage. And with COVID-19 in the early disease, people might not need huge amount of oxygen, but as the disease progresses, and we'll see how it progresses and how we can make sure that we figure out how much the disease is affecting that piece of lung or the two lungs, then we escalate oxygen therapy as per need and as per the symptoms and the signs, and each and every modality will deliver oxygen in a different way. Now, this is just a quick illustration just to remind all of us. For instance, if we have the nasal cannula, we call them the nasal bronchs, but we never deliver oxygen more than the 3 or 4 perhaps liters per minute. The mask with the Venturi connection. The one next door is the high flow nasal cannula. That is another modality of oxygen delivery system that delivers a good hydrated heated oxygen, and it helps, and it was found to be beneficial in patients with COVID-19. And you go as far as obviously in intubating patients. But before the intubation, people have spent a lot of time arguing around non-invasive maneuvers like CPAP or BiPAP by applying a mask with a very high seal index and with a lot of pressures, and high flow nasal cannula, and the difference between them and whether this is good or this is bad. The problem with non-invasive maneuvers is the aerosolizing technique, and unless you deliver it in a place with negative pressure, or in a place that the surrounding or the human beings leading the show or caring for the patients are fully geared up and dressed up, it might carry the risk of spreading the aerosol. Now, Venturi masks are important since they just deliver the oxygen in a higher bit of percentage according to the need. So this is just a little small device that you connect to the back of the mask and you connect to the oxygen cylinder, and it regulates. And as you escalate oxygen therapy, then you know for sure how much oxygen you're going to deliver to that particular patient. There is nothing that will deliver 100% oxygen unless if it was an ET tube, but other than that, anything varies between 24% up to about 70%. And this is just a schematic table to show you exactly how much with the color code, and the color code are international. And these are the kind of gadgets and simple things that should be available everywhere. It doesn't cost money, but it regulates that oxygen cylinder, and it regulates the flow of the oxygen, and it makes at least that cylinder that you get last longer, and you gauge how much oxygen goes to your patient. And as you can see, the flow rate will exponentially be related to higher oxygen delivery. And as you go with each and every choice, you will deliver up to about 85% through the non-rebreather mask, which is a mask with a rebreather kind of vacuum kind of bag. Now, and obviously we use that as an escalation maneuver, and the escalation can go from the simple mask up to the non-invasive, and if the patient is not doing very well, then we succumb to full-blown intubation and intensive care admission. Now, this is just to show the difference between the CPAP choice and the BiPAP. Essentially, they are the same, but when we have patients who have got pure respiratory failure type 1, characterized by severe hypoxia but normal CO2, we tend to use the CPAP. I'm aware of a lot of Sudanese families nowadays having the CPAP machine within their household. It's very tricky to be a normal person just to operate the CPAP. It has to be operated under the guidance of a doctor, because there will be some titration of the measures and the flows and the beep selection as per the oxygenation of the patient and the work of breathing, and hence why it should be under the auspices of a healthcare professional. And I would never, advocate for it to be used without support. And quite often when we start using it on a patient, when we have the facilities to have a baseline arterial blood gas, then we follow with another arterial blood gas the progress of the patient and the improvement. Now, going back to the SARS-CoV-2 or COVID-19 infectivity, everybody knows that the virus will not start showing itself unless if you contract it today, and then perhaps in the 5th day or the 7th day you start sometimes symptoms showing, but sometimes you might not. That's why the duration of incubation periods has been shown to go up to about 20 days, and hence why now the quarantining are around the 14 days, because virus can still be incubated at that particular time. But we usually see the peak of the viral activity around the 1st week, and hence if the disease is to really cause a lot of trouble according to your immune responses, then we tend to see that in the first 7 days onwards, rather than the first 7 days, 7 days and below. Just a quick reminder around the whole notion about why is it bad? Why is it not an easy-beasy kind of virus? Why is it aggressive like that? It is all because of the immune system responses. It's a new virus, so the immune system just acts very aggressively towards this virus, and it tends to differ from person to person, but it tends to fall within a mild disease or a severe disease, because with a asymptomatic disease, usually people do not complain, but usually with the mild disease, you start seeing the changes in functions, you start seeing some blood test abnormality, and usually the virus pushes you to produce an innate and later on an adaptive immunity. And with this, you will see a lot of shedding of T cells and the mainly the cytotoxic T cells, and at a later stage, neutrophils. And how big is that of a reaction then will be determining the stage of the disease, whether it's a mild disease or a severe disease. And hence why you will see that markers such as ferritin and D-dimers and CRPs will vary in their elevation and in their recrudescence later. But at the same time, they looked into markers that are cytokine in nature, including IL-2 and IL-6, and they were found to be those markers that kept going higher up even for longer period within the disease. And this is how we could say the combination of the high cytokines with the high symptoms and the failure of the symptoms to improve with deterioration of respiratory functions will make us diagnose severe disease. Now, in critical care, the main issue is the lung, but obviously extrapulmonary manifestations happen. But let's concentrate on the lung for a bit, because I think this is where we should take a lot of decisions based on the initial presentation. And it's important, because if we have such a patient getting iller and we see them deteriorating, there is no point in delaying admission to high dependency area or even considering intubation. There was a lot of stuff, said about early versus late intubation. And I think by and large now we'll see evidence to suggest that the earlier you intubate patient, the better will be the outcome. The less they will spend in ICU and the better will be the prognosis. But it's still early days, and I think I'm waiting for the data to emerge. And every day we keep waiting, we see more and more data. But essentially in ICU, respiratory distress syndrome is the main issue that we deal with. As intensivists, we depend on our diagnosis into making sure that we stick with our Berlin definition that looks into the hypoxia status, and obviously getting other ancillary variables, including the imaging and some more tests. But usually the arterial blood gases showing us the oxygen levels and the PO2 of the oxygen and the PF ratios, together with the radiographic severity, will give us an idea about whether the patient is that of a respiratory distress syndrome or not, because this will let us diagnose and then treat them accordingly. Not everyone in ICU having a ventilator on needs the respiratory distress syndrome treatment. Now, imaging is a very important issue. I'm aware of the fact that, for instance, in Sudan, it's very difficult to get a CT scan, but usually in places where COVID-19 hit hard, CT scan as an initial prognostic and diagnostic measure was the key. And you wouldn't obviously depend on the CT scan of the hospital, the departmental CT scan. You depend on having, for instance, mobile CT scanners that tend to catch those patients even before going to the inside of the hospital to try and diagnose them, because 50 to 60% of patients at the initial illness, and perhaps while they're having mild to moderate disease, might have a normal chest X-ray. So a CT scan is a very sensitive and specific tool to catch the disease early. Now, but initially, we might have the non-specific changes that we see with a lot of viral illnesses, but there are some specific things we see with COVID-19 in CT scan, and I'm going to go over them slowly. But the main thing is it is that of a peripheral pneumonia and a ground glass appearance that affects the peripheral lungs. And basically, it's hazy, but it doesn't obscure the underlying pulmonary vessels and bronchial structures. But this is the pathognomonic feature of this ground glass appearance. Now, as I mentioned, the opacities are quite peripheral, and they sometimes are geographic in distribution. They sometimes can be nodular or maybe not. But when we see it around in the CT scan like this schematic view, it's mainly lateral aspects. It can be basal or mid zones, but as you can see, very geographical and very characteristic, very characteristic. The nodular type, however, tends to appear in nodules and in specific areas. So you wouldn't see that in other diseases except with COVID. This is a specific nasty one. Obviously, it comes with the history as well, and how the patient presents, and the COVID positivity and all the rest of it. But this is very special around COVID-19. Now, there is another feature called the crazy paving appearance, where I've just put up a schematic view and a cartoon, like how we have in pavements with the pellets. It is basically that of an airspace and interstitial pneumonitis. And this is the feature that is compatible with the peak of the disease. So if we see something like that, then we are at our peak of the disease. And sometimes we see things like cystic changes. You just have a hole within the lung, and you ask yourself, where is this coming from? But it is just pure COVID. Now, fibrotic changes tend to happen at a later stage of the disease. Obviously, it could be reversible, but sometimes it could be irreversible. And we see the irreversibility in about 30% of the people who ended up intubated and with severe COVID-19 lung disease. This is another feature, the reversed halo sign. As you can see, it's just in the center with associated consolidation. And sometimes we see such a picture in organizing pneumonitis, but obviously COVID-19 has shown us such a feature. Pleural effusions tends to happen as well, but when it happens, usually there will be an indicator of secondary bacterial infection, and sometimes these patients do not do very well or stay longer in the ventilator or in ICU, and hence why their prognostic nation is not great. Rarely we see lymphadenopathy, masses, cavitation, but tends to be that of a superadded bacterial infection or a chronic infection, but it's not quite that of a COVID-19 issue. So the onset usually comes with fever, with the malaise, with the general viral-like illness, and obviously later on, shortness of breathing prevails, probably in day 4 or 5. The issue with COVID-19 is it affects patients in the mild to moderate disease, going into the severe disease with severe, profound hypoxemia. And sometimes you just see the patient, they're okay, happily hypoxic, we call them. And when you go into their arterial blood gas checking, they're very hypoxic, and you wonder, how are these people surviving? And again, this brings me to the shunting issue and the small thrombotic phenomena happening. Very rarely we see hypercarbia in those patients, and usually we just have to wait and see with prolongation of intubation and prolonged COVID-19 fibrosis, for instance, phenomena, CO2 retention might happen, but not at the start. 30% of patients present with renal failure, and usually the acute kidney injury is likely due to the fact that we don't give them enough fluids. They're very underfilled. The antibiotics we give hit the kidney more. There are really viral effects on the kidney, that's right, but we accentuated by our lack of fluid measurement that is optimum. 20% myocarditis, 30% the liver, we mentioned that, and of those coming to ICU, about 13 to 15% will need vasoactive materials, things like norepinephrine or things to help the blood pressure, because the blood pressure will be a problem as well. Very rarely we see pneumothoraces, but if we expose those patients to a lot of barotrauma or a lot of pressures, as we can see and we will see later, they tend to develop pneumothoraces. Now, let's talk about the evidence for what I just said, because it's very difficult to keep talking about things without having evidence. But at the same time, you have to understand the fact that the COVID hit us hard. We have received a lot of data from the initial countries that COVID hit, which is China, later on Italy. The world was busy dealing with the pandemic. Going on with randomized controlled trials would be very limited. And even if we want to do them, then we need the time. So we're still having paucity of evidence, but at the same time, evidence will be coming very shortly. I think there are some studies now producing evidence that is of a good quality rather than observation studies or meta-analysis. But I think with whatever we have right now in the intensive care group, there are no much evidence when it comes to randomized controlled trials in interventions, apart from a few things that we will discuss later. But in your formulation of evidence is not easy. You have to go through a lot of things before you come to a recommendation of some sort. And sometimes this recommendation might come out of no RCT. And hence why panel discussions usually are the important way by which we produce evidence in the critical care around COVID-19. And we have been very busy dealing with it in the last year to try and bring out the evidence out of the discussions around panels, experts coming from all over the world in certain areas, talking about each and every domain, and we have the best available evidence out of those expedited data reviews and publications. So basically, if we look into the statements that they produce, were mainly around the use of the best gear to stop you from exhibiting the disease or transferring the disease to yourself, which is obviously the N95, the surgical masks, and their use. So far, the best deal will be obviously to have an N95 due to the fact that the N95 has got the right pores to stop the COVID from spreading in and out, and to help generate a supportive environment to the doctor dealing or the healthcare professional dealing. Aerosol generating procedures usually are performed in ICU, and usually they are the intubation, they are the bronchoscopy maneuvers, there are a lot of maneuvers that the moment you touch base with the patient, you end up having this exposing yourself to the COVID virus and exposing the healthcare professionals to it. So it's advisable that these maneuvers take place in a negative pressure room that is specially or specifically engineered for this. And it's not easy to have a negative pressure room in any hospital, for instance, in the cell world. You have to build it, you have to have it from the start built for purpose. But again, if it is not available, then you have to be ready by providing your personal protective equipment and your gears to the people around you and around the patient. Basically, non-invasive ventilation, as I mentioned, took a lot of energy from all the intensive care world to try and come to a consensus, what is the best for the patient. And the jury is still out, but so far, the best evidence is with high flow nasal cannula that tends to be not available everywhere, but non-invasive maneuvers like BiPAP and CPAP could be used in a very controlled environment, bridging intubation. Unfortunately, doctors and healthcare professionals tends to be those people affected, and there are a lot of data coming from all over the world with a lot of healthcare professionals being the first martyrs, you know, to fall with this disease. And we recently have a lot of loved ones who died in our beloved country, Sudan. And it is again about the transmission, and again the gearing up, and again about the protection. Now, the personal protective equipments are just shown before you. It is no joke not to have a gown. It is no joke not to have a hair cover. It is no joke not to have a shoe cover. Everything is important simply because the virus can just go in through any place that is not covered to affect you and your family. Remember that you go back to your family, you need to be absolutely ready to be contaminating with them. You don't want to send the virus to elderly people waiting for you at home. So you have to be very vigilant. But I'm aware of the fact that this is, again, not easy to supply, but again, it's a human right. It should be available in places where we see COVID-19 patients. And unfortunately, you cannot have second best simply because you're talking about the fabric and about the transmissibility of the virus through it, and obviously the way the fabric will tolerate the moisture, and it's important. Intubation, again, the jury is still out, but early intubation tends to produce better data, better outcome. And obviously, how early is the question. But I think if you are really looking into your patient very closely and the patient is not trending into the right direction and becoming fatigued, then you have all the evidence from CT and X-ray suggesting the bilateral lung involvement, then there's no point in beating around the bush. Case fatality rate within ICU admission, people who had shock versus cardiac injury versus non-invasive or invasive, they tend to be variable. And again, the studies are all variable. Some studies used about 1,000 patients, very empowered study. Some studies used about only 40 patients. So it's very difficult to come up with a conclusion. But in general, if you've got multi-organ involvement, your outcome tends to be very bad. Cardiac injury, when it was reported in patients due to the COVID rather than due to medications. But obviously medications accentuate it, and it is 20%. So you have to be very careful about cardiac injury and have your echo ready to assess the patient and stop this from worsening, at least by very adequate or extra adequate fluid management, and you have to avoid cardiotoxic medications. Now, shock and other issues, we mentioned the risk factor associated with shock, but not shock as in bacterial shock or septic shock, no, shock due to cardiogenic shock. The evidence so far is lacking, but from our observation, when people end up having cardiogenic shock, it's very difficult to retrieve them out, unless if you have a center with VA ECMO and you can just push them there, but it's very rare that they come out. Now, in ICU, we use tons of medications to keep these patients sedated and well sedated rather than half-heartedly sedated, simply because of the fact that you need to control the environment and you need to offer the respiratory distress syndrome platform from the ventilation. And these patients cannot end up breathing with the ventilator. And that's why, again, another issue is the huge sedation medications, because the patients tend to spend in ICU between 2 weeks and 3 weeks. Imagine that they will be absolutely using this for all this time. They will end up becoming addicted to it in a way. So you have to keep the balance right. Medications that we use are things like propofol, things like fentanyl or opiates, morphine in general. And this cartoon shows you where to choose analgesia versus sedation and where to combine both, because sometimes we might end up weaning the sedation by adding more analgesia so as to reduce the longevity of those medications. Again, those medications are not easy. They will end up affecting the hemodynamics. They will end up making you add more vasopressors. They might end up causing more side effects and so forth. Vasoactive agents, it's been suggested that the choice when we have to give vasoactive agents is for adrenaline, noradrenaline. And if you need extra, then vasopressin or epinephrine will be the best. And this is a strong recommendation with high quality evidence. And mostly patients with COVID-19 behave like severe septic shock patients. So this makes sense. The direction is to keep titrating the vasoactive agent, to keep MAB or mean arterial blood pressure to be around 65 millimeters mercury and above, just to make sure that the perfusion to the other organs are fine. People who have got refractory shock, obviously, it came from the survival sepsis campaigns that steroids should be used in the dose of 200 milligrams per day, administered in intermittent doses. But again, we've got evidence from the recovery trial that at the beginning of the COVID illness, if you have the moderate disease with hypoxia, dexamethasone has shown its mortality data reduction, and we use it at 6 milligrams once a day for about 7 to 10 days with PPI cover-up. When it comes to ventilation, then it's the pure respiratory distress syndrome ventilation. It's not easy. You need special machines that have got the platform. You cannot bring a machine that is a ventilator used at home to use in ICU. Then you need special ventilators that have that platform. And we tend to escalate therapy up until ventilation, but we start from as low as saturations of 90% by giving oxygen, and then you escalate. And then obviously on the ventilator, after you finish the timing of non-invasive ventilation, you progress with the proper protocol. Now, there are some non-invasive maneuvers like face BiPAPs or helmet. Their use has not been validated yet, but again, if there isn't any other maneuver other than them, you might use them because it's either this or none. So you might as well just make use of anything that will get oxygen on board. So when it comes to do's and don'ts, I think the most important message here is do not delay intubation, especially if you see evidence of fatigue and hypercarbia and progression of the disease. Use high flow nasal cannula because it is less aerosolizing and easy to use, and it gives very good hydrated oxygen to the patient, and it can be easily maneuvered by people who can be upskilled quickly. In our critical care environment, we have a respiratory therapist to aid us in this function. In other developing countries, this might not be the case. The respiratory therapist is not available. So you depend on your nursing colleague to help with that. So this is the type of machines that you can easily upskill our nursing colleague on it, and you can make use of their expertise with them. When you mechanically ventilate the patients, then when you choose the protocol, you have to be patient, and you try and adopt a maneuver by which you do not give high peak in expiratory pressures so as not to cause barotrauma. But again, the jury is still out. But from experience, when I concentrated in giving PEEP less than 2 figures, that is to say 9 and below up to 5, and carried on with high oxygenation FiO2 and became patient, my rate of barotrauma was less. Now, this is something that people do not talk about, but again, it's a very cheap way of dealing with COVID, whether you are awake or ventilated, proning. It's evidence-based, it's cheap, and unfortunately in ICU, it needs actually the right expertise. It needs 5 people to be there to make sure that the proning happens correctly, the tube does not get dislodged, the patient is well looked after, because the timing tends to be between 12 to 16 hours. It might need some care for the skin of the patient, make sure that the patient does not end up having facial ulcers and so forth. But when it happens and the patients are really tolerating it, it tends to produce a lot of improvement, and definitely mortality data is better with proning. While proning on an awake scenario has got evidence based behind it as well, people are not yet advocating for it. But I think even people at home who have got this viral illness and COVID positivity, they can sleep prone and they might improve their oxygenation to the posterior part of the lung, and this might improve their prospect big time. And this is just to show you when even people are prone for this many hours, we use things like facial cradles, that like cushions, just to make sure that they don't end up having ulcers. Make sure that you just have your team, you guide your team into doing it. It's just a maneuver. And it just needs like 4 or 5 people who know how to deal with it, and in a coordinated way, you progress with it, and it does wonders. The use of continuous neuromuscular blockade or boluses of neuromuscular blockade is not advisable, but people with the severe respiratory distress might end up needing it. So I leave it to tailor patients and patient by patient approach rather than to continue on it, because it is not going to come without its side effects, including muscle issues and later on critical care neuropathy. At the same time, we might end up stopping feeding, and it's not advisable to stop feeding in those people. We set our ventilation parameters to make sure that the P plateaus are less than 30, and this is a function we see on the ventilator and we'll adapt to it. And this is suggested that if it is at any moment more than that, this might end up progressing the lung into fibrotic phenomena later on. So we have to keep that, and it's a prognostic factor as well. The use of vasodilator agents, including inhaled nitric oxide, is not quite advisable, but sometimes for few cases that you end up having difficulty in controlling the refractory hypoxemia, you might use it, but there is no evidence to suggest that it is of value. And again, it might even add to the aerosolized approach and the removal of the circuit and the interruption of the beeps. Now, obviously, with doing all that, and patients very likely to improve when you gauge it properly, but there are small amount of patients who do not do well, and hence why we think about other modalities like the ECMO, extracorporeal membranous oxygenation. It's a bit like lung dialysis, but I'm aware of the fact that this is just a very special treatment available in certain centers, but it's no harm in knowing about it. And in this case, we go for a venous ECMO, which is essentially just canalizing the patient through 2 major vessels, the internal jugular and the femoral veins, and you connect the cannula to an oxygenator, and there will be a console and a pump that will keep doing this and making sure that the circle happens to bring oxygenated blood to the human being after being removed from the body. And this just rests the lung until it improves, and at the same time keeps the functions of the organs up and going, because the oxygenation doesn't stop. Now, sufficing to say that it will be tempting while people are having the fever and having the high CRPs to have preemptive antimicrobial cover. It's not usually advisable at the beginning of the illness, simply because all what we see is all secondary to the COVID-19 and secondary to the huge immune response and the cytokine storm. So unless if you have proper cultures and cultures suggestive, we don't advise the use of empirical antibiotics, but sometimes patients might come to you already with the illness and with the secondary bacterial infection. There is nothing against empiric therapy until you proved otherwise. Always think about the future when you shed around these patients those medications without the gauge and without the knowledge. You have the risk of pushing MDROs to their roof, but at the same time, all antimicrobials, especially the top guns and the big guns, they don't come without side effects, specifically when it comes to things like carbapenems. You know, when you give them when patients are with renal failure, you have to really make the right choice in doses and so forth. So you don't want to sort out a problem by adding another problem, but a preemptive approach or empiric antimicrobials is not a wrong idea, but you have to have in your mind a de-escalation planning if you did not find any positive cultures. Remember, within critical care area, lines tends to be the problems that bring those infections most often. So you have your lines, you make sure that you culture them quite often, or you make sure that you change them when it comes to the time of the change. Paracetamol for fever, advisable, no issue around it. The use of standard immunoglobulins for COVID-19, not advisable. There is no place for it and no evidence so far. People talked about convalescent plasma. There is no place in routine use. Maybe there is a place when you are part of a trial, but definitely not for routine use for COVID-19 patients. And antiviral agents, that was the fashion at the beginning of the illness. People used Kaletra, lopinavir, tenofovir. People talked about favipiravir. Well, they are helpful in vitro, but obviously they're helpful at the beginning of the illness when people are even asymptomatic, when the viral protein is about to enter your body, maybe earlier on, but we tend to bring those patients, or they come to our care very late. So I don't think they made any difference to the outcome of patients when we started them. And we've seen recently things like remdesivir has been very much tried, and although it got a lot of publicity, but at the end of the day, it did not prove that it will be of help. It may be helped into reducing the ICU days of care from 12 days to 10 days or whatever, but nothing when it comes to mortality data. So interferon treatment, again, there is no evidence that recombinant interferons alone or in combination with antiviral agents can do any good to patients, and there is no evidence that they should be given. And obviously the story of chloroquine and hydroxychloroquine failed to support itself, and as far as I'm concerned, it just did harm, especially with patients who are with comorbidities, including diabetes and hypertension. They tend to have a very bad QT interval and arrhythmias with it. Tocilizumab's immunological agents, again, there was a huge keenness around it, but I wouldn't dare to do it. Remember the side effects of progressive fungemias and immunocompromised status without any additive effect on the outcome of the patient with COVID. Try and be generous with fluid therapy. I know that patients end up having respiratory distress syndrome and a lot of leak and overloaded status, but that's not the case. Intravascularly, patients will be depleted. There will be a lot of reasons to lose fluid. So if you want to make sure that you get it right, then there are ways by which you follow the fluid therapy of those patients, but you tend to be generous more than not generous. When it comes to ventilator management, we touch base with the B plateaus and the low tidal volume ventilation, which is anything to set your tidal volume between 4 to 6 mils per kilogram body weight, and be patient and try and avoid high peeps and avoid barotrauma. Now, other ICU measures, including feeding, it goes without saying, because usually patients spend longer in a catabolic, hypercatabolic status, and they will be emaciated by the end of the time. So you ought to feed them, choose the right calories and the right proteins, and make sure that you cover their gut with proper PPI cover. Skin is very important to be looked after, the longevity of them being at bed, the facial injuries or the facial sores, the sacral sores and so forth. And eye care tends to be forgotten. Keratopathy is something that is hidden. Nobody cares about it because they don't recommend it. But sometimes some people come out of the disease with a corneal ulcer or a keratopathy and blindness. That's not entertaining at all. So easy measures, it will not cost us nothing other than just the vigilant review and approach into keeping the eye as part of your organs that you look after and not to be forgotten. Importantly, staff dealing with patients with COVID-19 are those people who are doing it, continuously. They have got their own mental issues of anxiety, their household, what to do when I go back home, if there are PPEs covering, if there are not. At one point, PPEs were lacking. And this will pressurize us. The amount of deaths we see pressurizes people. So it's very important that we look after ourselves as well, caring for COVID-19 patients. It's not a joke. It's a debilitating patient to care for, and it's a debilitating disease because all the surrounding is so of a negative energy. So you have to come to ICU with that positive attitude to try and produce good outcomes, but at the same time, you have to do it together. If you're not caring for yourself and your nursing staff, then some people might slip through the net. When patients wake up and are weaned of ventilators, they might be delirious and aggressive. And this is, again, a side effect of the critical care stay and a side effect of the ventilation, prolonged ventilation and the medications that we kept giving. Emaciation and critical care myopathy is very important. So this might affect the weaning potential of patients. That's why we advocate for early tracheostomy choice for the weaning prospect. And we tend to choose it at day 7 onwards. So in the 7th day, if the pressures are okay and the patient is stable to the standard tracheostomy, do it is better than nothing. Now, a quick word about long COVID or post-COVID syndrome. Now, it's very recognized that this is now appearing many, many weeks after you get better of COVID. You don't have to sustain a very severe illness, but you might have a lingering disease that can continue up to months, 12 weeks rather, with debilitation and with malaise and with depression, with sometimes enough to cause suicide attempt. And we've heard about that. New York consultant ER, she was dealing with it at the beginning and she was found dead committing suicide. So we don't want to go to that extreme, but we want to at the same time appreciate the fact that these are potentialities and they are potential things that could happen out of a minor disease or even a severe disease. Vaccines, this is the, these days, everybody is talking about vaccine. Shall we take it? Shall we not take it? What is the vaccine that you like? Vaccines in Saudi Arabia versus UK versus Australia. I mean, a lot. I mean, we all know that the Chinese produce their Vericell or their Verocell or dead virus purified vaccine. And I personally did it and I had it about a month and a half ago and I'm fine. I didn't have any symptom or problems, but I was waiting for more studies to convince me and convince others to keep going. Unfortunately, when we went for the vaccine because we do not have other options. But again, the lack of the data made us a little bit unhappy to go for it initially. But at the end of the day, I think data is now coming and it looks like the Chinese vaccines are the straightforward vaccines, just the same like yellow fever or polio. It's use the dead virus that purified and they give it to you. One intramuscular injection followed by another one in 2 weeks' time. And you keep gauging your IgG responses. So far, so good. And I advocate for vaccines because we do not have any way out from a pandemic other than vaccinating all the globe. When it comes to mRNA vaccines, the one BioNTech and Pfizer are using or Moderna, they are not news to us as in the technology itself. The mRNA based therapeutics have been developed since 2005, you know, in the area of immunotherapy and cancer therapy. And it's an intelligent way of really hitting the virus hard and getting the huge immune system responses should you get faced by it. In a nutshell, it looks like they're all 2 doses. The interesting thing about the Pfizer and the Moderna is their temperature that you need to transport them in. Obviously, with the Pfizer BioNTech, it's very, very low. And it's like causing challenges into transmitting it from where it is produced to the rest of the world. But I think they're working their way out through that, and it is reaching all the globe as we speak. Now, it's variable into how effective they are, but at the end of the day, if we understand that, it will not stop you from harboring COVID-19, but it will make your infection less severe. So nothing will make you immune of COVID-19. That's why the bottom line is always to be safe and to not stop what you're doing. And essentially what you're doing is to look after your hands by washing, to keep your face covered with a mask, and to have your social distancing, and to make sure that when social distancing are affecting us and killing our public, we have to look into our culture. We have to reset and we have to stop what we're doing. In Sudan, the culture is making us have a wedding party full of 1,000 people. The culture is making us go to funerals and shed the virus along, and making sure that our productivity of the virus and infectivity and transmissibility of the virus is just higher, out of proportion. And when you come and look at it, it is simple things that we can just make us talk to them, simply because we cannot deal with such a huge pandemic ramification to linger around in our country. We don't have the resources, and we can just simply make a stop to that. And obviously they replace because of the ventilation issue. So a few references just, and I would stop here just to take a few questions. May I hope that 2021 brings us a very joyful year without COVID-19, because it's such a nightmare. And may I hope that all the rest of the world gets the vaccine and be prepared to deal with a mild COVID disease rather than a severe COVID disease that takes you to ICU. And with that, I just wish you all the best, and I hope that you stay safe, whether you're dealing with COVID patients or whether you are not. Thank you.
Thank you, Dr. Hala, for this actually interesting in every point of it. I'm sure you're all full of comments and questions. Now opens the door for that. Feel free just to raise your hand. We start with Prof. Salah Maghrabi. تفضل يا Prof. Just a minute. سمعني دكتور Prof. Salah Maghrabi. لحظة يا Prof. Unmute yourself, yeah, Prof. Dr. Salah. Prof. Maghrabi.
Okay.
Unmute yourself.
All right.
Yes.
Shukran, Dr. Hala, for a very, very comprehensive and very interesting lecture. We are very lucky to have 2 beautiful lectures, very comprehensive lectures within a week. Before they ask you the difficult questions, I'd like to ask you about the pregnancy. And if you've come across pregnant women who've had to be admitted to ICU, and how did they fare? And whether the delivery was essential or not essential. These are the questions that people keep asking about in terms of management of patients in the 3rd trimester.
Okay. Well, definitely I came across pregnant women. For a reason, pregnant women did well. Still nobody knows why, but within the few number of patients who progress to critical care, progression of pregnancy carried on okay, but in one of them we had to deliver the baby, Okay, so I don't think delivering the baby is an essential part, unless if it was affecting the mother, definitely. But so far, the minority of patients who got worse got the respiratory distress, but the majority did well in a ward environment. There must be something about pregnancy and COVID-19. There must be a protective phenomenon. Maybe we will find out around placental antibody. I don't know, but usually the pregnant women, wherever we find them, they should be treated exactly the same like other non-pregnant people. I think the focus should be on the lungs of the patient. You should follow the protocol, but thank God, whoever we saw were not having the severe way of the disease. And whenever we got them on the ventilator, delivering them was not an issue.
The Royal College agrees with you. Anyway, thank you very much.
Dr. Kirina, I guess the mic is yours. Unmute yourself.
Yes, regarding really just a nice session. We are really grateful having a really just very important every topics was held. Now my question regarding antiviral, regarding which stage I should as a whole, if in generally, which stage I should prescribe antiviral? In normally if for high temperature and coughing, but no other symptom other than ICU. In general, when I should prescribe it?
Sorry, Taysir, can you just repeat what she just asked? Because
Okay,
I couldn't.
Sorry, Tirina.
So she's asking about antiviral treatment.
I couldn't get the point. Sorry.
I think she's talking about antiviral treatment in general, whether they're indicated or not. Well, I mean, obviously guidelines guide us, but again, guidelines that came at the beginning of the disease really focus on antiviral therapy. They started by focusing on things like lopinavir, ritonavir, and later on Favi, Beravir, and all the rest of it. But again, we didn't have enough data to prognosticate patients when they got antiviral therapy. And I think now with the data available, antivirals tends to be an in vitro kind of thing, not an in vivo issue. So I find that when the patient presents to us, it's very likely that they bypass the initial phase. I wouldn't really be very pushy around antivirals. I will concentrate on the evidence-based stuff.
Okay, is that fair for you, Tirina? Okay. You may write it in the chat. I will press it again. Dr. Majid.
Hello. Assalamu alaikum. Thank you very much, Dr. Hala. It's really enjoyed this. Your presentation was done excellent, and it's really you cover everything. I just have few questions. The first question is that the response of the people to this COVID-19 is different. Is it related to initial viral load, or is it related to immune response of the person? Because some people, even with multiple comorbidities, they do well. Some people with no comorbidities, they do bad. And some people are not obese, they do bad. Some obese people, they get well. It's not very clear. This is one. The second question, I noticed that in the second wave in Sudan, the mortality among physicians is very high. What is the reason? Is it because they don't use
Okay.
Majid,
I think I got the hang of the question. Okay. All right, Majid, shukran jazilan. Well, I think it's very difficult, but I think viral load or immune responses, I think I'll choose the immune responses. I mean, depend upon the immune responses of the host, and I think this is what led to the huge kind of we call it the L type and the H type, and will they, you know, this is the demarking things. But I think how good is your immune system and how bad is your immune system and how bad was the hit was the thing. I don't think it's related to the viral load. Maybe I'm wrong, but so far there is nothing to suggest a viral load of viremia is proportional to worse prognosis. Now, in Sudan, now this is a very tricky question, but I think I'm going to be very honest and open in answering it. Now, we have the resource issue in Sudan. That's why when we started, we did not have the proper testing, tracing attitude. We woke up to know that we have got a COVID-19 disease. We were not doing very well in teaching our public because our public are still taking it very, very lightly. Is that the problem of the public or the problem of the, the healthcare professionals? Now, added to this, if you are in a place with no testing ability and you don't know exactly what you have, you cannot manage, you cannot measure. So you cannot tell about the community transmission. So you go to a funeral, as I mentioned, or you go to a super spreader situation, you end up having people intermingling. And this is exactly what led to people dying of COVID-19. And I will add the third factor is whoever people, healthcare professionals wise, whoever are practicing and dealing with patients, they are not supported with the gear, with the PPE. So I think the combination of the three will probably answer your question. Now, the question is not whoever died. Whoever died should have died not in vain. They should have raised the awareness for us not to get more and more people to die. So I think the situation there has to really be reviewed and assessed. Guys, in the last 4 weeks, if you look into Sudan and the domestics of Sudan, we witnessed many scenarios to be super spreader. We witnessed a big peace party that was attended by millions of people. Obviously, you won't know the effect of that until 2 or 3 weeks after that event. The problem is the party was attended in Khartoum, but obviously the ramification will go to the rest of the Sudan, where the resources are even weaker. We kept witnessing a lot of other super spreader scenarios. The same will happen now in Europe. Now Europe is really panicking around Christmas and the New Year's events and the parties that can happen and generate from them. That's why they called for a complete lockdown. So I think we need to look into us. We need to really improve the knowledge, practice, and attitude of our normal Sudanese public towards the disease, and we need to hammer on that. I want to just switch on the Sudanese media with all the channels just to see or to listen to someone talking about COVID-19 and making public aware. I would not find that. I couldn't find it. And I feel so bad and so ashamed. So, and hence why we group ourselves around this live shows, we talk to each other, but that's not enough. That's important, yes. But the thing that should be enough is the leaders of the country, the public should know that this is a very, very tough deal. They better stop 1, 2, and 3 before they claim that they are under control. And I will concentrate on the cultural behaviors. And I will concentrate on the doctors looking after those patients. They should be really looked after. They should be really covered. They should be given the right PPEs. And I will concentrate on making COVID-19 the problem of the whole of the country. I use at the beginning of the thing, I was joking with my colleagues, and it became a very important part of our lives. It's like we eat COVID, we drink COVID, we sleep COVID, we dream COVID. We cannot do otherwise until we get rid of COVID. And obviously this will take a long time. It's a marathon, it's not a sprint.
Thank you very much. Can I ask a question, please? Because I have a co-host, so I cannot raise my hand. Thank you very much, Dr. Hala, for your comprehensive overview. I just have actually 2 questions. One is, what would you do with a patient who came to the ICU with a D-dimer extremely high, and when will you use therapeutic heparin in the ICU, right, when it's actually very difficult to confirm that they have got thrombosis? you know, just transporting them out and doing.
Exactly. You know, in ICU, all decisions should be taken when you balance things. But I think with regard to COVID, I will blindly put the patient in 1 milligram per kilogram body weight of Clexane, BID, unless if there was a huge contraindication like bleeding. So without any question.
Right. So you go for high dose, almost therapeutic anticoagulation.
Therapeutic,
right?
Until proved otherwise. Yep.
Right. Okay. And supposedly you just have a high D dimer. When would you stop the anticoagulation?
Well, D-dimer will not be that thing that guides me into stopping anticoagulation. You know, I will stop anticoagulation when the patient is not hypoxic, when the patient is out of the ventilator and showing features of improvement, because I think D-dimers will lag behind for many, many days, perhaps 2 weeks. And they are not only the function of thrombosis, they are the function of the immune responses of the body to the COVID-19. So the simple answer is I will advocate for full dose Clexane or equivalent, like a therapeutic treatment when the patients are with moderate to severe COVID-19 and hence ARDS, and I'll stop when the AA gradient is good.
And actually, the reason I'm asking is because I was speaking to a colleague in Britain yesterday, Dr. Luay Osman, I think his other surname, and they are actually becoming very cautious in using therapeutic anticoagulation in Britain because of increasing bleeding risk. But I think what you're advocating is probably the general theme in ICUs all over, in most countries, to use a therapeutic. And just a message to Dr. Taysir, because I have a recording from Professor Motasim. So at the end of the presentation, if Dr. Taysir will give me just 5 minutes, but I'll leave the floor now for the others because I can see quite a few questions there.
Hello, assalamu alaikum. Actually, I have, thank you very much, Dr. Hala, our great teacher. My question is that, or my concerns and worries about the vaccine in general, or the way the vaccine has been made, and other issues that the vaccine have been made in a very limited time compared to other vaccines and so on, and the way that it delivers. So this generally, but I'm asking a specific question. What about this vaccine in pregnant ladies? Is it safe to take it or not?
Right. Okay. Thank you very much for the question. Now, vaccines, yes, came out in a very short period of time simply because nobody in the world of virology or vaccinology was doing nothing other than producing a vaccine. And I think I'm quite aware of probably more than 130 vaccines being tried. And the ones that came out after finishing phase 1, phase 2, and phase 3 of the trials were the ones that we're hearing about: the Moderna, the Pfizer-BioNTech, the Chinese ones, and the Johnson & Johnson, the AstraZeneca, Oxford. They will come along. So the phase 1 is when you review the vaccine in a very small number of patients, or perhaps less than 50 or 100. Phase 2 is when you go up in numbers, and phase 3 is actually when you expose about 1,000 to 3,000 people to the vaccine, and you see the side effects of pharmacokinetics, how the patients behave, and how you answer all the questions around the side effects and problems. But obviously, long-term side effects, nobody knows about them simply because of the time restraints. But as far as we all know, when we look into COVID, when we look into the vaccine and how it will help reducing your chances of having a very nasty COVID disease and improve the herd immunity, I think we choose the vaccine. And when you look into the types of the vaccine, the mRNA versus the dead virus, yeah, you might have a little bit of an issue here. What shall I go for? Well, so far, the evidence suggests that they are all safe. When it comes to pregnant women, I'm not going to be the person answering that, but as far as we're concerned, from whatever I've heard about the virus, and the vaccine, pregnant women were not excluded, and it seems to be okay for the baby and the pregnant women. So I'll ask Dr. Salah to answer if he's got any additional thing. But I think you should feel that at least we've got evidence to suggest that the vaccines are safe to take them. And this pandemic will not be under control unless a vaccine is globally given to people. Whether you choose the dead virus, the Chinese one, versus the mRNA virus, it's entirely up to you. But again, none of them will stop you from harboring COVID. It will just make your deal easier.
Okay, thank you.
Thank you, Dr. Hala. From the chat, we have a question. One of my colleagues asked about the vaccine in children. Open question, vaccine in children. Is it safe?
Well, I think the vaccines so far are directed towards a certain group of people, people who are elderly, people who have got risk factors. They're not directed towards children. The good news about COVID-19 in general, it affected children, but it did not affect them with severe disease. And when it came to severe disease, it came in a special category of diseases, which was the Kawasaki. Vaccines are going to be given to people about 16 years of age. So now children will be included until we see what they are going to advocate for in the coming few months or so. And maybe because the disease, when children have it, they tend to have a very milder disease anyway. But so far it is for adults, and immediately in the coming few weeks, we'll see those people at risk getting it, and then the rest of the population.
Okay, thank you. Okay, Dr. Safa Rahma, تفضل يا دكتورة. دكتورة صفاء.
Assalamu alaikum, everybody. Hi, Dr. Hala. Thank you for an amazing lecture about the COVID. Dr. Hala, I'm asking about the post-COVID time when you have to discharge the patient when they are really stable, but they cannot maintain good saturation. That means they end up with some intrinsic lung problem like fibrosis or so on. What is the evidence about this? How you can discharge them on home oxygen, or did you face some cases like this?
Yes, of course. I mean, you are likely that you will face this category of patients, but it's multifactorial. It could be due to remaining fibrosis of the lung, all right? And this tends to be I don't know exactly how much, but probably around the 10 to 20%. But the most important thing is people who are having difficulty in breathing because of critical care myopathy. This is the criteria or the group of people that you need to offer rehabilitation, feeding, physiotherapy. So it's not always easy to jump out of ICU to home. You have to make sure that they get the right rehabilitation. And I think in order to know where you are with the prospect of fibrosis or not, you have to go with proper testing, including CT scans and pulmonary function tests. These people will end up probably needing some form of non-invasive ventilation for some time. And if they have trachs, they might need a small ventilator at home to support them, or a non-invasive maneuver, until you wean them very slowly. And again, the weaning is not a matter of a day or a night. The weaning is a program. It's feeding, it's physiotherapy, it's care, it's psychology, together with obviously lung exercises and sputum management as well. And obviously treating underlying secondary infections comes earlier.
Hello, everyone.
Yes.
I would like to ask about, as you said before, first of all, thank you for the nice talking about COVID disease. I would like to ask about, you tell us before, the prognostic features, and the prognostic test will be on changes on CT. That mean any COVID positive patient will have the changes on CT scan, or just the severe ones?
No. Yeah, very difficult to prognosticate, but you know, when you have moderate to severe disease, the radiologist will look into the CT scan in a certain way, and they will tell you how much of those lungs is affected by the severe ground glass appearance. The more the affection is, that tends to be related to the severity of the disease. And then later on, they found that prognostically, when you have high cytokines, including IL-6, together with the ferritin levels that keep going for a longer time, these people tend to be of a poorer prognosis. And obviously, you collect a poorer prognosis if you stay in ICU for longer and you become iller with another organ failure. So the prospect of having multi-organ dysfunction will carry more and more of mortality data. Okay, so that's why we can work hard to stop the kidneys from progressing by making sure that our fluid therapy is right, by making sure that we do not choose the wrong medications with the wrong dose to affect the kidneys, by making sure that we exclude obstruction or obstructive uropathy and treat it, and so forth. And we make sure that we do not miss myocarditis and try and ignore or remove medications that tend to impose a QT interval abnormality and a potential for arrhythmia, for instance. So a lot of things we can do in order to stop the progression to multi-organ dysfunction. But disease, the majority of people who did badly are those who had very nasty ground glass appearance with severe hypoxia that was not refractory for the first week or two of their stay in ICU. Obviously, plus the cytokines.
Thank you, Dr. Hala. Dr. Muhammad Tariq, تفضل Dr. Muhammad.
Thank you very much, Dr. Hala. Thank you very much for such an valuable and enriching session. I think it will, we're really going to benefit from it. But I will take you back to our discussion, if you remember, a couple of weeks back. And now your session, it starts to get more worried in regard of Sudan when it comes for the vaccine. What do you think? What are our best options? I mean, looking into what's happening and following up on the media and following up on too closely with the Minister of Health from Sudan, I don't know. I have a feeling that they are not much into. There are no plans. I mean, or maybe this is the message that I got. So, do you like to elaborate, and taking an opportunity also to have our senior physicians with us here, and as we say, the creme de la cremes of our health sector. Okay, now we know everything about the disease. What are the implications? What will the solution will be the vaccine. So what are the plans? What are we going to do?
I think there should be pressure to have the vaccine in Sudan, like other countries. I mean, every country have had plans or made plans to provide the vaccine to their native people. And I think how to avail it, and then this is the job of the politicians to deal with. But I think through the WHO and all the institutions that support the Sudan, the Gavi, the WHO, the whatever it is. I mean, you should have your share of the vaccine. There is no excuse for that, and I think this is a humanitarian issue, and no one will not will not be supposed not to have the vaccine. As simple as that. So I'm not quite sure about the arrangement in Sudan, but I will advocate to have the vaccine in Sudan, as simple as that. It will be obviously very, very tricky regarding the cold chain and everything, but I'm aware of some countries who are far away from where the vaccine is produced in Europe or in America. They managed to get it with the right cold chain of -70 Celsius, and they are giving it to their native people. So having the vaccine is a must, because there is no way that we can wake up every day to a community transmission and no herd immunity, and to people becoming sicker and sicker and needing extra care and critical care, and we don't have resources. The vaccine will be the best.
But time is a factor, صح? Time is a very important factor.
Well, I can't agree more, and that's why I think maybe I don't know, but I mean, our voice has to reach people, and
Exactly.
When politicians listen to science, they tended to control the situation within their country. And I'm sure through your platform here, a lot of people listen to you, and a lot of people hear out what you get to say. I'm very happy to add my voice to your voice in order to push for a vaccine to be available in Sudan. As simple as that. That's not a brainer. That's not rocket science. It should be.
Yes, I think so. Thank you very much.
Any question?
السلام عليكم.
مرحبا.
في واحد عنده سؤال ولا I can say something? لو دكتور تيسير معانا ولا ما معانا؟
جون يا بروف معاك يا.
في سؤال ثاني ولا لانه بس في حاجه شورت اوديو من بروفيسور محمد المعتصم. He wants to just to share with everybody.
Okay, you can present, Prof. Go on.
حاجه for people who don't know Professor Muhammad al-Mu'tasim, he's a senior radiologist and a well-known figure actually in Sudan and also in the Kingdom of Saudi Arabia. So he actually wanted to give you a short talk earlier in the presentation, but he had to go and see a patient. So I will just put his audio on, and it's only about 4 minutes. So I will just start the audio now.
طيب بسم الله والحمد لله. الحقيقة في نهاية هذا العام يعني لابد من وقفة. قليلون هم الذين يوقدون الشموع في عتمة الليل البهيم، بل قليلون هم الذين يحترقون ليضيئوا الدرب للآخرين، وقليلون هم الذين يقتطفون الليالي من أعماق محيطات العلم، يقدمون الياقوت على طبق من تواضع ومكرزات، وقليلون هم الذين يتفرغون لتحويل الممارسات العبثية إلى منهاج علمي وموثق ومحكم. التحية لشباب الطبابة والشيوخة، التحية للراهب المتبتل الأخ بروفيسور عصام صلاح أحمد حسن، رئيس وحدة علاج كبار الزوار واستشاري علوم الصدر والالتهابات والمناعة في مستشفى الحرس الوطني. تحية لقيادته الرشيدة، والتحية معه كمان للشاب رقيق البنية، رقيق المشاعر، رقيق الخطاب، لكن رخيم العطاء وكبير الطموح وثقيل الموازين، ابننا تيسير الطيب الذي ما فجأ وما انفك وما برح، يجاهد ضد انقطاعات التيارات ويتواصل معنا ليل ونهار ويستدرج الناس لتقديم العطاء، وكله بإشراف الدكتور الإمام الدكتور محمد الفاتح. I actually never had my country witnessed such a committed effort for transformation that evades vicious circles of micromanagement, pettiness, hierarchy plans, things that have only crippled our healthcare services. All of you at Altababa, visitors, members, listeners, have formed a consortium for better problems identification first, sound root cause analysis, structure and valid recommendations for a better practice on scientific evidence-based attitudes كما تعلمنا من بروفيسور إيمان. I dare say in conclusion that in 2021, Altababa has now established itself as an institute of health, independent of all other institutions, but committed in its quest for excellence to share knowledge. Unreserved donation of facts and knowledges to our young people. I do claim that Altababa in 2021 should start producing and issuing postgraduate qualifications as diplomas and fellowships. We're no more with this power of brains and power of will and these eminent figures around us in here. We should not settle for less than being an institute of healthcare improvement. Thank you very much. وكل عام وانتم بخير.
الحقيقة يعني نشكر بروفيسور محمد المصطفى على الكلمات الطيبة. الحقيقة دعم زملائنا وأساتذتنا ده يعني ما كان حافز عشان احنا نواصل. بروفيسور محمد المصطفى، بروفيسور مغربي والكثير الحقيقة من الزملاء. الحقيقة أبشر الدكاترة إنه وزملائنا في الحقل الصحي إنه فعلا الطبابة in its final stages to actually launch its first evidence-based practice diploma في السودان. يكون إن شاء الله أول دبلومة للevidence-based practice مش بس في السودان بس لكن في أفريقيا كلها. فإن شاء الله قريبا ترى النور بجهد دكتور تيسير، وإن شاء الله قريبا evidence-based practice diploma becomes a reality in Sudan and it's going to change the practice of medicine by everybody in Sudan. أنها هي أحد if you introduce the important concepts of how to improve practice. الحقيقة معلش يا دكتورة هالة يعني البروفيسور محمد منتصم قال لازم في نهاية العام، وطبعا شرفتينا بمحاضرتك القيمة الغنية، وهو قال لازم تخلونا أقول لك كلمتين ديلا، فأخذنا بس 5 دقائق من وقتك ونشكرك ثاني مرة ثانية دكتورة هالة.
طيب هذا سمحت لي بروفيسور صاد الحضور الكريم، معلش the first time to say يعني something like that. هي لعلها اكتسبت لنا emotional لأن آخر سيشن في المشروع الناجح الإكسباتريس لينك أوفيس أو الإكسباتريس أونلاين سيشنز، وزي ما قال بروفيسور محمد المعتصم يعني بروفيسور عماد فضله علينا كبير، ودائما بنتذكر زي ما درسنا بروفيسور عماد ومن بعده الدكتور الغامدي واحدة من محاضراته، نحن زي السربي بتاع الأويز طبعا، زي السربي بتاع الجيز. ما مهم انت تكون واقف وين او انت ماشي قدام ولا ورا، انت فوق ولا تحت، في الاخر انت كلك بتهيئ التيارات بتاعت الهواء للسرب اللي وراك عشان يمشوا. ما مهم ابدا منو العمل الحاجه الفلانيه، المهم انها اتعملت. انا ما كان حكون موجود الان لو ما انه زملائي كانوا ساعدوني وكان محدوا لي الطريق انه اكون موجود الان معاكم. ما في واحد بيقدر يعمل حاجه في الطبابه ما لم يكون زملائه هم الداعم منه. ففعلا في ناس بيظهروا فينا لكن ما معناته انه الفضل لهم، هي الفضل لكل التيم ولكل الفريق. To manage something is totally different from leading it. وكونك تعمل يعني really transformation مختلف تماما انك انت تعمل change. نحن من اول يوم تعلمنا انه لازم نكون احنا transformative leaders to lead a transformation مش to lead a change. ولازم نكون leaders في بيوتنا، في منازلنا، وسط اسرنا، لزملائنا، في محل شغلنا، ما نكون just managers. فكونه انا بظهر معناتها ما معناتها انا الفضل ليا، الزملاء من وراي كتار زي ما اشرت. كونه فلان بيعمل حاجه معينه وبيشوفوه في الميديا ما معناته هو الفضل ده له، هو كل التيم معانا سوا وكلنا باذن الله تعالى. وزي ما دايما بقول للشباب نحن خاتين الله قدام عيننا وخاتين هدف واحد علمنا له بروفيسور عماد، السودان ومواطن السودان البسيط. اتمنى كان بروفيسور محمد معتصم يكون موجود معانا. لو بتذكروا في محاضره من اكسباتريس سيشن في اكتوبر الوردي قال لنا نحن حننزل من القندفه بتاعت الكرافتات وحنمشي لاهلنا الطيبين، فشلنا كاميراتنا وشلنا حاجاتنا وعملنا شاشه كبيره جدا بالتنسيق مع اخواننا في التامين وعملناها في ساحه الحريه، لانه كان الهدف بتاعنا مش الاطباء بس، لكن كان الهدف هم الكنداكات اخواتنا واماتنا. الحشد حضروه 700 نفر لايف على الهواء مباشره، وكان حاجه جميله جدا. ده الهدف اللي نحن نسعى له في النهايه. كلها زي ما بيقولوا ماشيين، وتبقى الذكرى السمحه وتبقى الحاجه الحلوه. ومعلش انا طلت عليكم. شكرا يا بروفيسور عماد، شكرا كل الحضور الكريم، وشكرا اعضاء البورد، شكرا دكتوره هاله. ختامه مسك فعلا دكتوره هاله، وانا افتخر انه انا يعني انت كنت تلميذ بالنسبه لك، بتحديني في سنه سادسه، صح ما عاطيني شويه لكن الحمد لله مشيت الحمد لله.
جزيلا كتر خيركم، شكرا جزيلا. انا سعيده جدا اني اكون النهايه، لكن دي نقول بدايه العام الجديد. ان شاء الله نكون مع بعض تيم واحد ونعمل اكثر، ولسه البلد منتظره مننا اكثر من كده. مشكورين جدا وكل عام وانتم بخير وكتر خيركم.
يعطيك العافيه دكتور هاله، شكرا.
خير عافيه.
شكرا دكتور مغرب، شكرا سادة الحضور الكريم. نلتقيكم كل سنه وانتم طيبين، وعيد استقلال مجيد. نتلاقى السنه الجديده ان شاء الله على خير. السلام عليكم ورحمه الله وبركاته.
وعليكم السلام.